Today we are going to be talking about the CMS OP35 measure. The Centers for Medicare and Medicaid Services proposed 7 new measures for the calendar years 2018, 2019, and 2020. The proposed changes for calendar year 2018, 19, and 20. The Hospital Outpatient Quality Program is a pay-for-quality data reporting program for outpatient hospital services. The Hospital OQR program requires hospital outpatient facilities to meet administrative data collection and submission, validation, and reporting requirements to receive a reduction of 2% in their annual payment update for failure to meet these requirements. In the calendar year 2017 Outpatient Prospective Payment System and Ambulatory Surgical Center proposed rule, CMS is proposing to add a total of 7 measures to the Hospital OQR program for the calendar year 2020 payment determination and subsequent years. 2 claims-based measures and 5 outpatient ambulatory surgery consumer assessment of healthcare providers and system survey-based measures will be included. The Outpatient 35 measure, CMS measure, includes admissions and emergency department visits for patients receiving outpatient chemotherapy, which assesses the care provided to cancer patients and encourages quality improvement efforts to reduce the number of unplanned inpatient admissions and emergency department visits among cancer patients receiving chemotherapy in a hospital outpatient setting. In 2017, a measure dry run was conducted. A measure dry run was a preliminary analysis of data in which facilities were able to review their measure results and ask questions about and become familiar with the measure methodology. The measure dry run included patients receiving chemotherapy in any hospital outpatient departments during a 1-year period from October 1, 2015 through September 30, 2016. The measure dry run used final action fee-for-service claims processed by CMS as of January 27, 2017, and excluded denied claims. Inclusion criteria for the dry run and for the current CMS OP35 measure includes all adult Medicare FFS patients with a diagnosis of cancer age 18 years or older, infusion-based chemotherapy treatment HOPDs identified using current procedural terminology, CPT, Healthcare Common Procedure Coding System, HCPCS procedure, and medication procedure codes, and international classification of disease 9th revision, ICD-9, chemotherapy and counter diagnosis codes, ICD-10-CM and ICD-10-PCS. Codes are revenue center codes for chemotherapy administration. It uses specific ICD-9 and ICD-10-PCS on inpatient claims to identify chemotherapy services subject to the CMS 3-day billing rule. Oral chemotherapy is not included. Exclusion criteria for the dry run and the current CMS 35 measure excludes patients with a diagnosis of leukemia at any time during the performance period, excludes patients not enrolled in Medicare FFS Parts A and B in the year before their first outpatient chemotherapy treatment during the performance period, excludes patients who do not have at least 1 outpatient chemotherapy treatment followed by continuous enrollment in Medicare FFS Parts A and B in the 30 days after the procedure. Defining a qualified admission or ED visit. The measure calculates 2 separate rates, hospital admission, ED visits. A primary discharge diagnosis of one of the following: anemia, dehydration, diarrhea, emesis, fever, nausea, neutropenia, pain, pneumonia, or sepsis. A primary discharge diagnosis of cancer and secondary diagnosis of one of the 10 diagnoses listed as a secondary diagnosis. ED visits or hospital admissions at other facilities will also count as qualifying. Data was collected at the facility for the first quarter of 2018. The data collected included patients that met the inclusion criteria for Medicare, Medicaid, self-pay, and private insurance. Data was collected on cancer patients treated at an outpatient hospital, infusion center, and medical oncology clinic. The infusion center averages 25 patients per day. The data was also collected on patients admitted to the inpatient oncology unit. The top 3 diagnoses that met inclusion criteria at the facility were sepsis, pain, and febrile neutropenia. The CMS believes that all 3 of these diagnoses could be prevented and are treated and managed in the outpatient setting. Research has shown that malignancies such as non-infectious systemic inflammatory responsive syndrome, SIRS, can mimic sepsis. So, physicians have to consider that a patient may have SIRS and not sepsis. It is important that physicians and nursing staff focus on preventative action with education and therapeutics for sepsis. Patients need to be educated initially before receiving treatment, but need to continually be re-educated regarding sepsis and neutropenic fever. Research is currently being done regarding pain associated with chemotherapy-induced peripheral neuropathy. Treatment of this type of pain with a high-dose 8% capsaicin patch has been proven to be effective in clinical trials. Studies have shown that chemotherapy-induced neuropathy can be treated with pharmacotherapy, physiotherapy, or behavioral training. Timely treatment of febrile neutropenia is key. There are many types of infections that can cause neutropenic fever in patients receiving chemotherapy and include bacteria, anaerobic, fungal, viral, and polymicrobial. Some of the research reviewed did voice concerns about the fairness of the CMS measures. One article pointed out how physicians will treat patients in order to meet the CMS rule. For example, there was a CMS rule that required physicians to prescribe antibiotics to patients that had a discharge code of pneumonia within 4 hours of presentation. This CMS rule caused patients that probably did not need antibiotics to receive antibiotics, and research showed that there was no documented differences in pneumonia mortality rates and that there were more cases of Clostridium difficile. What research shows is that prevention is key. Number of patients that meet inclusion criteria. The numbers included in this data is just the Medicare patients that met the inclusion criteria for the CMS Outpatient 35 measure. In January, there was 5 patients. February, there was 4 patients. March, there was 3 patients. Total for the first quarter of 2018 equaled 12 patients. For those 12 patients that did have ED visits and or admissions, the problems that they came in with included 5 with sepsis, 1 with pneumonia, 1 with neutropenia, 4 with pain, and 1 with dehydration. Patients that came in through January through March of 2018 that met the criteria, the 12 patients, 7 of those patients had lung cancer, 1 had colon cancer, 2 had multiple myeloma, 1 had head and neck cancer, and 1 had prostate cancer. For the 12 patients that met the inclusion criteria for January through March, what day of the week did they come in? 1 of them came in on a Sunday, 3 came in on a Monday, 2 came in on a Tuesday, 2 came in on a Wednesday, 1 came in on a Friday, 2 came in on a Saturday, and 1 came in on a holiday. 4 of the patients went to the ED during clinic hours, so one of the questions asked was, did these patients call the office? That is something that further research needs to be done to determine if they did. Were they directed to go to the ED, and why not? And why were they not referred to come into the office? So that's some additional research that needs to be done. Additional facts: if a patient has an ED visit and then is admitted, only the inpatient admission outcome will be counted. The qualifying time period for each outcome is an admission or ED visit within 30 days of receiving a specific chemotherapy treatment. If a patient would present to the ED or be admitted more than once in that 30-day time period, it will only be counted as one outcome. Suggested solutions: observation stays do not count in this measure. If a patient could be seen in the clinic instead of being sent to the ED, and if the admission is needed, have the patient admitted from the clinic as an observation patient. That would be a better option since observation stays are not counted in the measure. Have a full-time triage nurse that answers calls and assists patients. Currently, patients just leave voicemails and then the nurses call them back when they have time. I think going forward, one of the best things that they could do is have a full-time triage nurse to answer the patient's calls as they come in. Providing more education to patients before treatment and during treatment, and extending hours of the infusion center, staying open later in the day, and having weekend hours. Don't you realize that your body is the temple of the Holy Spirit who lives in you and was given to you by God? You do not belong to yourself, for God bought you with a high price, so you must honor God with your body. 1 Corinthians 6:19 through 20. Honoring God by keeping our body healthy is key, but sometimes we do become ill. and have to seek medical care. It is important that as healthcare providers that we allow God to work through us in helping to get our patients well. If you will listen carefully to the voice of the Lord your God and do what is right in his sight, obeying his commands and keeping all his decrees, and I will not make you suffer any of the diseases I send on the Egyptians, for I am the Lord who heals you. Exodus 15:26. God is the ultimate healer. He heals us. And it is important as Christian healthcare providers that we seek his will and allow him to work through us to heal his children, to heal our patients. Dear friend, I hope all is well with you and that you are as healthy in body as you are strong in spirit. 3 John 1:2. God wants us to be strong in spirit, not just in body. And to do so, we have to seek his will and be obedient and allow him to guide us. Collecting data and using it to evaluate effectiveness allows for leaders to assess if measures are being met. Leaders must develop skills to assist them with managing resources and improve care. Leaders must use the American Nurses Association scope and standards of practice to guide them. There are 5 leadership practices that leaders should possess to be successful. They should model the way, inspire a shared vision, challenge the process, enable others to act, and encourage the heart. Then a scope of standards that were followed or used in this capstone project included Standard 1, assessment, collecting data, documentation of data. Standard 2, identifies issues, problems, or trends. Examines and synthesizes data, derives issues, problems, or trends, documents issues, problems, or trends. And Standard 3, outcomes identification, involves stakeholders in formulating expected outcomes, defines expected outcomes, documents outcomes as measurable goals. 2 more ANA scope of standards that were used in this presentation included Standard 5, implementation, implements of plans, collaborates with stakeholders, incorporates new knowledge and strategies, and Standard 7, quality of practice, uses creativity and innovation to improve care, drives quality improvement programs, assures development, implementation, and programs to improve quality of care. In conclusion, the CMS OP35 measure will start affecting reimbursement in the year 2020. This allows time to discover issues and resolve them. Overall, for 2018, few patients are having ED visits and being admitted that are included in this measure for this facility. Concerns have arose about the CMS Hospital Acquired Condition Reduction Program. Some research has shown that there appears to be bias in the CMS Hospital Acquired Condition Reduction Program. One research study did reveal that bias can occur when hospital quality is evaluated using measures that are based on occasional events and a performance threshold. Another research article did provide evidence that there are concerns about the HACRP penalty model and how it is used to determine penalties for hospitals. But overall, the CMS had established this measure in hopes to improve the health of populations, provide a better care experience for patients, and lower costs.